Thank you, Katrina, and thank you, Natalie and Anna, as well. You'll see from this first slide, so that the picture on the left is the actual guidance that I'm going to talk about, supporting and valuing is really important, as I'll talk about more, valuing lived experience of mental health difficulties in clinical psychology training. And as you can see from the 4 names on the slide, Natalie, we were very lucky to recruit her to help coordinate and write the guidance. And the other 3 authors as well worked alongside Natalie to produce the guidance. Having said they're the 4 authors, there was actually a huge working group on the guidance, and I'd just like to say as well that we were very much informed by early conversations that we had with the Royal College of Psychiatrists and the Royal College of Nurses. And we hope, even though the guidance is about clinical psychology training, we hope it's going to be useful for other professions, other healthcare professions as well. It was co-produced with stakeholders within the clinical psychology training community in the UK, trainees, trainers, clinical supervisors, many of whom are experts with experience, or EPPEs, to borrow Ahmed's terminology, or wounded healers, if we prefer that. The guidance was supported and published by the BPS, but it was also supported by the ACP-UK, which is the Association of Clinical Psychologists, an alternative organisation for clinical psychologists. And you can see the number of people involved. I won't read out all the names, but we warmly thank them for their involvement as well. Lots of different courses and representation from supervisors and trainees and trainers. So we talk quite a lot. I think we've got an idea of the context from the talks we've had today, but as we've been talking about the work and course cultures, maintaining an us versus them narrative for many years, pressure on mental health professionals, as has been talked about in depth today, to appear invulnerable, to remain on the side of the helper, and the real need to support and value trainees with lived experience. The guidance was actually published last September 2020, but we thought, particularly given the pandemic, it was really important to hold an event to kind of launch it properly, which is what we're doing today. Just before it was published, the BPS, the British Psychological Society, the Division of Clinical Psychology within the BPS, published a statement on clinical psychologists with lived experience of mental health difficulties, which I think is a really important statement, because it speaks, as you can see here in the quote, to the unique and valued contribution that lived experience of mental health difficulties brings to individuals working within clinical psychology, and the importance of actively valuing in aspiring trainee and qualified clinical psychologists that lived experience, and saying it can help to enrich practice and improve service provision. And I think Ahmed and also Natalie and Anna have spoken to it, how it enriches practice and improves service provision. Within that statement, they talk about they make five statements, which I think are all very important and a good summary really of the context for why guidance is important. So lived experience of mental health difficulties is common, as several people have spoken about today. If anything, it's more common amongst mental health professionals and doctors and other healthcare providers than it is in the general population, which is certainly at least as common. Lived experience of mental health difficulties is diverse, and this is very much speaking to things not getting hijacked by the wellbeing agenda, but really being about all kinds of mental health difficulties that, as Natalie has spoken to, go beyond things to do with the pandemic, being sections someone's spoken about already, the whole spectrum of mental health difficulties from the acute to the chronic are important when we're talking about lived experience. Decision making, as people have already spoken about today a bit, about showing mental health difficulties is a very complex thing, and we'll look at that in a bit more depth in a minute. The importance of destigmatizing lived experience and addressing discrimination is a whole system responsibility, and that's been quite a theme today, hasn't it? Not locating it within the individual, but seeing it as the whole system needing to be doing something. And also that lived experience is an asset, that it's to be valued. Also, it's worth mentioning, we haven't got time to look at it today in any depth, but the BPS also published a document, a position statement in April 2021, I think it's a resource they call it, called Building a Caring Work Culture, What Good Looks Like, which very much is quite similar to what Katrina was talking about earlier, about building compassionate workplaces, and what people have talked about today, about how the system needs to be compassionate. So turning to the guidance that we've produced with our colleagues, I want to just run through the key aims and principles. So The purpose is guidance for the training community to increase the likelihood that trainees with mental health difficulties will be supported and will feel supported, to recognise explicitly that mental health difficulties are common amongst mental health professionals and those in training, to challenge the silence, the stigma and the shame, to create a culture of compassion and openness, to normalise and value, so a normalising and valuing stance, to help people understand, to know when to ask for help, and to understand that doing so is a sign of professional competence, that very much framing it as a sign of professional competence, which I think links very nicely into the point Charlie was making earlier about redefining professional, seeing it as very much part of being a professional, asking for help. And perhaps most importantly, to provide some good practice examples and information about multiple sources of support for trainees and trainers and supervisors. So we very much asked all the training courses involved and the people involved in producing the guidance to give examples that were working well. I'm going to run a whistle-stop tour, given the time, through 7 parts of the guidance. So setting the scene, creating a culture of openness and compassion around lived experience, understanding confidentiality, sharing lived experience and mental health difficulties, support for trainees experiencing mental health difficulties, taking time out for those trainees who need to take time out, and perhaps most importantly, because it's the biggest fear I think amongst trainees, demystifying professional ethics and fitness to practice. So first of all, in terms of setting the scene, we went with the language mental health difficulties or mental distress or lived experience, but we very much invite people who are going to use the guidance to adapt that language if it doesn't work for them, to use whatever language works for you. As the BPS commented in their document that I talked about earlier, we wanted to address the full range of mental health difficulties. So kind of really recognise that as humans, we suffer the whole range of mental health difficulties. And as I mentioned, a whole systems perspective. So really collaborating with course staff, trainees and placement supervisors. We're also very mindful as well of the NHS Staff and Learners Mental Wellbeing Commission report in 2019, and the real fear of learners. I'm reminded of Caroline opening today, talking about thinking her working life was over and saying she was making a light disclosure, but I thought actually it was a very powerful disclosure. It was very interesting that that disclosure to us was obviously made 30+ years later. But this is a real fear, I think, amongst people with mental health difficulties, lived experience, that there's a real fear my life's going to be over, my working life's going to be over. So creating a culture of openness and compassion, by which we mean a culture where trainees and staff feel able to talk openly about personal struggles and lived experience. The idea that all involved in training should think about how they perceive and talk about lived experience. And we should avoid assumptions that trainees will not have experienced particular difficulties. So occasionally we'll have a lecturer in and they'll talk about something and there'll be a kind of assumption, explicit or implicit, that nobody in the room has experienced that, when actually it's likely quite a number of people in the room will have experienced what we're talking about. So in terms of good practice, how do we do that? How do we create a culture of openness and compassion? So lots of nice examples from various courses across the country. So first of all, supervisor training in supporting trainees sharing mental health difficulties. So in supervisor training that courses provide, to encourage supervisors to think about their own relationship to lived experience, both their own lived experience and others' lived experience, to reflect very carefully on the impact of the power imbalance in supervisory relationships and how that might impact on what can and can't be discussed. And also encouraging supervisors to model and create a culture in which openness is normalised, to put on the agenda talking about struggling, talking about lived experience. One of the things we've done at UCL is we've introduced a Mentimeter, a bit like the one we did before the break, where we ask Year 1 trainees early on in the induction to say anonymously if they've suffered, if they have lived experience. And usually it's way over 50% of the room have lived experience, and that also helps to create a culture of openness and tackle stigma. We also have some vignettes of trainees. So what happens if I struggle with this on the course? What will happen? To take people through what actually happens rather than the fear of what might happen, which is often, I'm going to be chucked off the course, and as we'll see, that's pretty rare. Staff openly talking about their own lived experience in lectures. Some courses have trainee-led groups for those with lived experience, which can be very validating. Lots of courses have independent personal advisors, who are people they can discuss whether and how to share lived experience, support in accessing personal therapy. A few courses in the UK do actually have resources of personal therapy. Most courses in the UK provide information about personal therapy, and also thinking about issues of personal resonance. So some people may have lived experience in a particular area and feel more equipped to work in that area on placement. Some people might feel they don't want to work in that area because of personal resonance. And similarly with research, encouraging people to have open conversations about that with tutors or those involved. It's interesting, turning to confidentiality and understanding confidentiality, that we do a lot of work in clinical psychology, as I'm sure other healthcare professions do, about confidentiality of patients or service users, and making sure we're clear about the limits of confidentiality with them. But we're often much less clear about the confidentiality in relation to trainees. So we wanted to do some good guidance around confidentiality, a key guiding principle being the need to know. You can imagine a trainee who's with lived experience might have an anxiety. What's going to happen if I share my past or current mental health difficulty? When will confidentiality be broken, both with and without consent, and how will it be broken? So the guidance suggests that it's really important to have a clear confidentiality statement in relation to confidentiality and mental health difficulties. And that it's good to share this with trainees early on in training, so they know what happens about information, they know who it goes to and how it goes to people. Also, they can have conversations maybe with their course tutor, but it's also important to identify an alternative member of staff in case their course tutor and they don't have a great relationship, and that they feel they want to be able to turn to someone else. A key section of the guidance is on sharing lived experience. So deciding whether, and if so, how and with whom to share lived experience is obviously context dependent, and there's no one size fits all to this. It may be that you disclose more in a particular situation or with particular people than you do with other people. So what the guidance does is it directs you to resources to help make decisions around sharing. So one of those resources, Honest, Open, Proud, Ahmed's already talked about today, and which is a manual to help weigh up benefits and costs of sharing, and a template as well for how to tell your story, which you can adapt in different contexts. So it's not that you write the whole story and share everything. You might decide in one context you share some of it, in some context you don't share any of it. Other resources, Heads Up have very good resources and guidance for employees to plan a conversation about mental health difficulties at work, tools to weigh up potential costs and benefits of sharing. And there's also quite a short guide, which is very practical and helpful, called Conceal or Reveal, or CORAL it gets called. And so there's links in the guidance to those. Isolation, as I think we've heard a lot of today, is very common when people are professionals with lived experience, and it may be very helpful to link with others, and certainly Integrate Mental Health has been a fantastic resource for people to link in with and find other people in similar circumstances that they can link with. Social media is obviously very helpful, or has been very helpful, in promoting open conversations about mental health, and lots of anti-stigma campaigns, which we've also mentioned today. But it's really important carefully to consider the implications of trainees sharing on social media. And there's a reminder from the BPS Ethics Committee about sharing on social media being traceable even after it's been deleted. So that needs careful thought. It's also worth mentioning that the guidance doesn't go into detail about sharing lived experience in the therapeutic relationship, largely because that research is in its infancy. So simply states that it's important carefully to weigh up the potential risks as well as the benefits, and to think very carefully about the particular client that's being worked with. Just checking on time here. Yeah. So support for trainees experiencing mental health difficulties. Both trainee and service users need to be kept at the heart of thinking, and safeguarding service users must obviously be taken seriously. So we're talking here about situations where things are particularly difficult, and maybe the trainee struggling with working with clients. So far as possible, it's helpful to have 3- or 4-way conversations between trainee, core staff, supervisor, and occupational health. It's really helpful to involve the trainee in deciding what, if anything, peers are going to be told, so that they kind of don't just disappear for a few weeks and then reappear, for example. Avoid the need for multiple conversations as well. It's helpful to have a named person the trainee can talk to, and really helpful for courses to provide information about various sources of support. I've just got a time warning, so I'm going to speed up slightly. You might need to make reasonable adjustments. There's some examples of reasonable adjustments which you might need to make there in collaboration with the trainee. And we also link to other resources from other organisations that we think are very helpful, for example, Mindful Employer and ACAS. Some trainees may need to take time out, and again, we want this to be framed as a strength in a trainee's professional development, as an example of competency in action. And think through with the trainee what's going to be shared, if anything, with peers and other staff. Set up how they're going to keep in touch, how frequently they're going to keep in touch, how that's going to be done. And also, very importantly, returning after time out, think about what adjustments need to be made, about how they're going to join the course again. Really helpful to set up a safe space to discuss what lived experience has brought to their professional practice and supervision, if that's what they want to do, and the possibility of sharing this with others. A key fear is I'm going to be chucked off the course and not be able to practice. It's really, trainees need to self-regulate to some extent under the HCPC guidance, but at the same time, training programs must ensure a compassionate context where trainees feel able to come forward to discuss their need for help. Fitness to practice is very rare. You can see I put a picture here saying rare with a tick, because it is very, very rare. And these are some examples of where it might happen. But the key message we need to give from the outset to trainees is it's a very, very rare thing for that to be what happens if you start sharing lived experience and talking about it. I'd like just to end with all of you, whether you're clinical psychologists or not, thinking about where next for you. So what I'd like everyone to do is to really read through and please widely disseminate the guidance, because I think it is helpful, whatever healthcare profession you're in, to think about what narratives or conversations or regulations there are within your systems or contexts about mental health difficulties, lived experience, burnout, resilience. What impact do these have? What could be done to change those unhelpful narratives or conversations? What might help to break the silence, encourage openness? What steps can I personally take to help to value staff with lived experience within my setting? How can I help to foster a compassionate and open work culture? And really importantly, who am I going to involve as stakeholders? So these are kind of questions for everyone, I think, to think about from today. Okay, I'll stop there in the interest of time.